Let me share again. Okay, I think now it goes. First, as usual in these international conferences, this is the financial disclosure of the perceived conflict of interest. As you can see, I am heavily involved in research with different implant companies and also different companies dealing with regenerative products. So to start, let me stress the importance on the soft tissue seal around dental implants.
Quanh implant. Dear professor, we do not see your screen. Can you?
You don't see my screen?
Yeah, yeah.
Okay. Let me share it again.
Yeah. Thank you.
Do you see it now? Do you see it now? Do you see my screen? Do you see my screen now?
Yes, we can hear you.
You can you see my screen?
Yes, we can see.
Okay, sorry.
Thank you.
So I was trying to stress the importance on the soft tissues around dental implants. Because clearly when we place a dental implant, our goal is to achieve osseointegration, that is the direct contact of the bone with the implant surface. But this osseointegration will only be maintained if there is an effective seal in the soft tissues around dental implants. And as you can see from these histological images, the soft tissues around dental implants, which normally adhere and adapt to the abutment, have different qualities. Some have a white connective tissue core, some have a very thin connective tissue core, some have a wide band of keratinized tissue, others have a very narrow band of keratinized tissue. And these qualities of the soft tissue seal are going to influence heavily on the long-term outcome and maintenance of peri-implant health. So with this small introduction, and I hope you can hear me well, I will present to you this lecture organized in these 3 different chapters. First, I will discuss the importance of the keratinized mucosa and the different surgical interventions that we use to augment the keratinized mucosa. Second, I will discuss the importance of a certain thickness of the peri-implant mucosa and the different techniques that we have to augment the thickness of the keratinized mucosa, of the peri-implant mucosa. Second, and finally, I will discuss the importance of the coverage of peri-implant dehiscences in those situations when there is a loss of the height of the peri-implant tissues. So let's start with the keratinized mucosa, and I hope you can see well my slides and you can listen to me. It is clear that when we lose teeth, with time, we also lose the width of the keratinized mucosa. And the alveolar mucosa basically creeps and occupies the space where the alveolar crest once had teeth. Therefore, when we place implants, many times we have very narrow bands of keratinized tissue that we need to share around the recently placed implants. For many years, there has been controversy on the relative importance of the keratinized mucosa around dental implants. Is it important to have a certain width of keratinized mucosa to maintain the health of the peri-implant tissues. You see, this is a publication, which is actually a systematic review of systematic reviews. So it is a publication that has evaluated the different systematic reviews on the significance of keratinized mucosa on implant health. And as you can see, there are 4 systematic reviews that were published before this paper in 2017. And here you have the number of studies. So you see it's a quite ample number of studies that have dealt with this issue throughout the different years. And the conclusion is that all these systematic reviews have reported a positive association between an adequate width of keratinized mucosa, normally more than 2 millimeters, and peri-implant health. However, we still do not have enough data to evaluate what is the impact of the lack of keratinized mucosa on the survival of the implants. But what it is clear is that when there is a lack of keratinized mucosa, we have problems to maintain the health around these particular implants. This is a very important study by an Italian colleague, Mario Roccuzzo, who evaluated retrospectively in his private practice, prospectively, during 10 years, the impact of 3 groups: the group that had keratinized tissue, the group that did not have keratinized tissue, and the group that did not have keratinized tissue but was supported by a free gingival graft. So the lack of keratinized tissue was treated by a keratinized tumor graft. And when we compare the different parameters, the bone levels, probing depth, bleeding on probing, plaque index, soreness, you see that mostly in terms of recession and in terms of soreness and in terms of plaque and even bone levels, there was a statistically difference between the group that did have versus the group that did not have keratinized tissue. So it is important to realize that in many cases, when there is a lack of keratinized tissue, such as around these implants on this 3-unit bridge, we need to evaluate the indication of augmentation. And in the classical literature, there have been several techniques, surgical procedures that have been indicated for keratinized mucosa augmentation, from periosteal retention techniques, denudation techniques, vestibuloplasty. Basically, techniques were based on raising split thickness flaps and apically positioning those thickness flaps, aiming for a re-epithelialization of the area that was left denuded. Basically, all these techniques lended themselves to a lot of recurrence of the same problem. After a certain amount of time, the alveolar mucosa rebounded, and the situation was similar to the situation before the surgery. And that is the reason that today all these techniques, classical techniques, are not in use. We only use grafting techniques because the graft is the only way to prevent this recurrence of the position of the mucogingival line and alveolar mucosa. So let me share with you this simple surgical video that clearly shows the basic technique, how we raise a split thickness graft, and then we position that flap apically, how we take a free gingival graft from the palate, and then on this periosteal bed, we basically suture the free gingival graft, basically to provide a width of keratinized tissue that when healing will heal with keratinized mucosa. So the surgical intervention is very straightforward. Sometimes it's not easy to perform in the posterior mandible because the lack of vestibular depth, and also the harvesting of a free gingival graft evidently is going to leave an open wound in the palate that needs to be cured during the post-operative period, and patients have some, although usually mild, morbidity. However, this is the standard of care, and as you can see in these cases, when the second stage surgery to unsubmerged implants that were placed under the mucosa, it is at the same time placed a free gingival graft to provide a wide band of keratinized tissue around these mandibular implants. In order to prevent or to avoid this morbidity of harvesting of the palate, since already more than 10 years, soft tissue substitutes in the form of collagen matrices of xenogenic origin were released and were researched for this indication. You see, the method of action of these collagen matrices is that they provide a scaffold of highly porous connective tissue that allows the ingrowth of connective tissue from the surrounding inside the matrix, and with time the matrix will bioabsorb, and the connective tissue with capacity of keratinization will occupy the space and develop keratinized mucosa. This principle was tested in an experimental in vivo investigation that we published some years ago, where we evaluated the added effect of a collagen matrix when performing an apically positioned flap in sites without keratinized mucosa. And you see from these images that the spaces inside the keratin matrix are occupied by the fibroblasts, by the vessels, and they will, with time, turn into mature connective tissue with the capacity of inducing the epithelium to keratinize. As you can see, this is a clinical case of lack of keratinized mucosa around these dental implants, lack of vestibular depth, how we raise a split thickness apically positioned flap, and in the periosteal bed that is created on top of the bone by the split thickness dissection of our flap, we place the keratin, the collagen matrix that is submerged, that is left to heal unsubmerged once it is fully sutured to the adjacent sites. It is clear that this matrix is going to collect tissues from the site, which, as you can see, have the capability of keratinizing, is from captain because these are derived from the alveolar mucosa. So as you can see, the final outcome into 3 millimeters, but this is unstable portion of tissue that separates well the marginal mucosa from the underlying alveolar mucosa. Our research group published a couple of randomized clinical trials, basically to compare the outcomes of this intervention using matrix with connective tissue graft. According to this randomization, one group was treated with a connective tissue graft harvested from the palate, and the other group with the collagen matrix. As you can see, at baseline, before the intervention, the parameters that we measured, the keratinized tissue, gingival index, probing pocket depth, recession, were basically similar in the basic differences. And 6 months later, you can see in terms of the width of the keratinized tissue, the collagen matrix group attained as a mean 2.5, the connective tissue graft as a mean 2.6, no difference between the groups. When we measure morbidity, that is the amount of painkillers that the patients had, you see that significantly less pain and less morbidity was referred by the group with the collagen matrix, which is obvious because they did not have the secondary surgery that is needed to harvest the graft. And this was exactly the same obvious in terms of surgical time, because the avoidance of this second surgery turned into a lesser amount of time. So here you see some clinical cases where we perform this apically positioned flap. And as you can imagine, only the tissues coming from the sides will have the capability of keratinizing. But by placing the collagen matrix, basically this serves as a scaffold to collect tissues coming from all directions. And the endpoint, of course, is going to be a band of keratinized tissue, which is not big, but it is big enough to maintain over time. Now we have the 5-10 years follow-up of these patients, and those who have maintained a good plaque control, maintain these margins without inflammation, are very stable and maintaining this amount of tissue. So as I alluded before, in this keratinization process, it is a kind of a race from cells coming from the sides, cells coming from the bottom. And in order to slow down the cells, the tissues coming from the alveolar mucosa, we have designed a modification of this surgical intervention to enhance the amount of tissue that we can generate using a collagen matrix. And as you can see, this is a patient that we have done regenerative lateral bone augmentation. This is before, this is after the bone augmentation. But of course, in order to cover all the regenerated bone, we advanced the mucosa and we ended with a minimal amount of keratinized tissue. So this is the modification of the technique. Basically, we do the apically positioned split thickness flap, but we go to the palate and we take this very narrow strip of a free gingival graft, a very narrow that will allow us to close by primary intention, not leaving a wound in the palate. And this band of keratinized tissue in the apical end of the flap will prevent the cells from the alveolar mucosa to gain rapid access to the area where we would like to develop this band of keratinized tissue so that we favor the ingrowth of cells from the side. And this is, as you can see, the outcome. We can see the maintenance of the strip of free gingival graft that we placed. And you see the beautiful amount of keratinized tissue that we were able to develop, since in a way we stop the growth coming from the bottom. You see the quality of the tissue that we are able to develop. And this is the final restoration in this particular site, which clearly is in a beautiful situation to be maintained over time. Basically, using this principle together with Dr. Itzvan Urban, we published a modification of this approach to treat large areas in the maxilla or the mandible when there is a need to enlarge a lot of tissue. And of course, we wouldn't have enough palate in a patient's oral cavity to provide free gingival grafts for these areas. These are areas that have had extensive vertical and lateral bone regeneration, where tissues had been advanced to cover these areas, and therefore we need to reposition the mucogingival line and to create a large area of keratinized mucosa. So basically the principle is the same. We fix this strip of free gingival graft that we take from the palate, and basically we place a large matrix in all the periosteal bed that we have below this free gingival graft strip. And you see how eventually with time, there is of course some shrinkage, but even with the shrinkage, we have a large area of keratinized tissue. And you see that in both the posterior and anterior maxilla, you see from the surgery that we aim to increase around 10 millimeters, 1 centimeter, we end up with about 5 to 6 millimeters, which is a very good area. And as you can see, the median and the mean at 12 months, about 6 millimeters of mean, and about 40% of shrinkage, but enough to have, this band of keratinized tissue. This, of course, can be applied to defect areas in the maxilla, in the mandible, and like in this particular case, in many situations, large areas to cover, we may even combine free gingival grafts with collagen matrices in areas that are large and we don't have enough palate to harvest. We recently have published, again, this last year, a paper with another indication for the collagen matrix, which is the surgical treatment of peri-implantitis. And in many occasions, patients with implants that suffer peri-implantitis have deficient areas of keratinized tissue. And we combine the apically positioning of the flaps to access and decontaminate these implant surfaces with the placement of, in this clinical trial, either a collagen matrix or a free gingival graft. And you see we treated about 58 patients randomly assigned to either the collagen matrix group or the free gingival graft group. And the end result you see at 6 months and 12 months was that the amount of keratinized tissue was clearly higher in the free gingival group, but we attain as a mean 1.6 millimeters, with some cases do not attain in anything, other cases attaining up to 3 millimeters, and also attain a good amount of vestibular depth that was always inferior to the free gingival graft. So in essence, the free gingival graft always provides more amounts of keratinized tissue. And you can see here in this graph, when we plot the millimeters of keratinized tissue to the months, and you see at the end of the year, you see in red, the collagen matrix patients, they are all around nested around this area between 2 and 3 millimeters. You see there is one that we didn't get anything. And the blue ones, which are the free gingival graft, the behavior is more widespread. Some cases we got up to 8 millimeters, and other cases we got very little. But most of the cases are spread more in this high end area, 4 to 8 millimeters. So you see, when you place a large free gingival graft, you are going to get a higher dimension of keratinized mucosa. When you place a collagen matrix with the different variations, you are going to get a certain amount, not a large amount, small amount, but normally is sufficient for maintaining the stability of the mucosa around these implants. And of course, in all these studies, always the morbidity associated with the grafting was heavily reduced by placing the soft tissue substitutes. So the second of the indications that I would like to discuss with you is situations where the loss of the teeth and of course the cause why the tooth was lost, infections, periapical problems, periodontal problems, all these situations are going to end up by a net loss of tissue. And this net loss of tissue clearly affects the alveolar bone, but also affects the soft tissues and the loss of contours. It is clear that even in I would say, highly ideal situations that I have only one tooth that is lost with the adjacent tooth in health, the loss of a tooth in the anterior maxilla clearly causes a loss of the buccal contour. Of course, depending whether the patient has a high smile or a low smile, patients will or will not show the alveolar contour, but it's clear that with the presence of teeth, we have these radicular prominences that make the alveolar contour clearly convex, while when we lose one tooth or two, this convexity is going to turn into flatness or even concavity. And this may cause an aesthetic outlook when the patient smiles, because the patient will have basically a shadow that will be reflected in the loss of the contour. So in order to provide this convexity, in order to provide a better emergence profile to our restorations, the state-of-the-art technique is, again, the use of grafts. In this case, not free gingival grafts, because these grafts will be submerged under the mucosa. So it will be connective tissue grafts, connective tissue grafts that need to heal submerged under the mucosa. And the whole purpose of these connective tissue grafts is to provide enough volume to change from a flat or a concave contour to a characteristic convex contour of our dentitions. And you see this particular patient that we place an implant because there was no problem with the bone availability, but the patient had clearly a concave profile. So we just did a connective tissue graft, and we changed from a concave to a convex profile. And this, of course, can be measured readily by visual inspection, or we have today digital means to evaluate the thickness of the contours that we are able to augment. And of course, the emergence profile of these implant supported restorations, in this case, implant supported crown, provide a good aesthetic outcomes. Basically, from this situation, another clear indication for the use of soft tissue grafts to improve the buccal profile has been the immediate implant. And as you understand, the immediate implant is a very attractive surgical protocol when we decide to extract the tooth, and when we also decide that the best option to restore that tooth loss is by placing an implant. So the decision to place an implant immediately provides the patient with lots of advantages, mostly rapidness, avoidance of time with provisional restorations, and of course, also provides the opportunity to augment the hard and the soft tissues around these immediately placed implants to try to restore the tissues that would be lost by the mere extraction of that particular tooth. So in these clear situations, like in this case with a horizontal fracture at the level of the bone that is not restorable, in these situations also, that as you can see, we have a good bone area in the palatal side of the socket, so situations where the stability of the immediately placed implant is not on jeopardy. These are the classical situations that the immediate implant placement provides a good treatment opportunity. However, this immediate implant protocol has aesthetic challenges, and mainly because of the soft tissue recession, the soft tissue shrinkage that will occur when we remove the tooth and place the implant. So in order to compensate for that loss, soft tissue grafting is indicated mainly in these anterior maxillary areas, where we know by lots of epidemiological studies that the thickness of the labial bone is less than 1 millimeter, and normally the tissue phenotype is thin. So it would be extremely risky in these anterior maxillary situations to place an immediate implant without the appropriate hard and soft tissue compensation. So in these patients, if we have an area like we have here of tuberosity tissue, this is probably the best tissue to harvest because it's tissue that is poor in fatty tissue, but is very rich in fibers. So it withstands the pressure, it maintains the volume, and even if we are going to compress with our sutures when we close the surgery, the volume will be maintained by the connective tissue fibers. So in these situations, we normally implement this classical surgical protocol that we do a flapless, very careful extraction, we normally place a narrow conical implant that basically enhances the implant stability by engaging in the palatal wall of the fresh extraction socket. And then we go to the tuberosity, remove. Normally what we do is we remove as a free gingival graft, and then out of the oral cavity, we de-epithelialize this. We basically section this piece of tissue into halves, and then we de-epithelialize both halves. And this sort of butterfly wing shape tissue, we inserted under the mucosa. We develop a kind of a submucosal split thickness envelope flap. We do not raise the interdental papillas, and then we suture this connective tissue graft to the mucosa, and then we stabilize this connective tissue graft to the mucosal tissues. And then secondarily, we are going to graft the gap between the implant buccal surface and the alveolar bone, and we are going to place a provisional immediate restoration that will maintain the position of the soft tissues, and they provide the adequate positive pressure to maintain this volume gain, to maintain this convexity. So this is what you see in 1 week: beautiful healing with the maintenance of the convexity, and you see the enhanced thickness that we have created by the connective tissue grafting. So you see how whenever you use autologous grafting, the amount of volume that you generate is large, and therefore you are going to get basically no problem with attaining a good convexity and a good emergence profile for this restoration. That in a patient with a high smile line, this is very important to maintain the stability of the outlook, and of course, at the same time, maintaining the stability, long-term stability of the peri-implant health. Can we do the same with soft tissue substitutes? Because as you saw, we can do almost, not as much, but almost the same for augmenting keratinized tissue. Well, basically, we published about 3 years ago a paper where we basically adapted the immediate implant technique to use soft tissue substitutes, and we evaluated the amount of tissue, hard and soft tissue compensation that we attain by placing a xenogenic bone substitute together with a collagen matrix soft tissue substitute. And using this technology of combining the DICOM images from the CBCT with the STL images from digital impressions, we were able to evaluate the amount of hard tissue that we were able to attain on the buccal surface of these immediately placed implants, as well as the amount of soft tissues, and how the thickness of soft tissue may compensate the amount of new bone that is developed. And this is the data. I'm not going to go in detail on the data, but what I can say is that we were able to maintain most of the profile from the pre-extraction to the basically 1 year post-extraction when we evaluate the whole ridge profile after the final restoration. And basically, this is, in a nutshell, the